Alrighty, good morning, everyone. My name's Khoi. I'm from Portland, Oregon. First, I'd like to thank Sig and Jim for inviting me to participate in this year's Innovasis meeting. I think it's been a great meeting, and I'll try to get us back on track so we can hit the slopes. So these are my disclosures. Innovasis isn't on the list, but I wouldn't mind it if it were. So over the next 10, 15 minutes, we'll talk a little bit about the history of MIS TLIF. We'll talk about the technique, and I have a video that was put together during my time at Michigan, and we'll go over some of the literature. First, a quick poll. How many folks in here are doing MIS TLIF? So a lot of people. And of those who are doing it, how many are you doing it tubular? Okay. How many are doing it more like a Wiltsey type approach? Okay, great. So, the TLIF procedure itself was first developed by Dr. Harms in the early 80s. And then more recently in the mid-2000s, the minimally invasive tubular approach was described by Dr. Foley. And just to go over the steps of a TLIF, this is your exposure. The spinous process, if you're doing a laminectomy, can be removed, as well as the inferior facet and some of the superior facet as well. The nerve roots retracted, not bitten, but retracted. Thoradiscectomy is performed, and cage is placed. And it's very straightforward. You know, I do quite a few of these. It's probably my most common primary surgery that I do, and this is a video that we put together. This was published in Neurosurgery Focus and is available on YouTube. So this was an elderly person who presented with back pain and leg pain, clear L4-5 spondy with stenosis. And of course, many good ways to approach this, whether it's ALIF, OLIF, lateral, and TLIF. And the reason I have preferred TLIF for these cases is because, well, one, it's a single position. You essentially have no risk of bowel or vascular injury. You're not working through psoas muscle, and TLIF, as opposed to the more antiquated PLIF, essentially requires no to minimal nerve root retraction, and so the risk of nerve injury also is quite low. So in doing these cases, most of my MIS training was with Paul Park at Michigan. Back then, we would use 2 fluoro machines and K-wires. Patients positioned prone on a Jackson table. He would generally mark the lateral aspect of the pedicles and then align about a centimeter more lateral to that. I kind of just go based on the lateral aspect of the pedicles. And then using biplanar fluoroscopy, you can place the K-wires in the standard minimally invasive way. My techniques progressed a little bit to first using just 1 fluoro, hitting in all the needles in AP first, making sure they're not breaching the medial aspect of the pedicle, and then swinging the C-arm into the lateral position, and then tamping it the rest of the way into the vertebral body. And since then, my institution, unfortunately, is a little bit behind, probably about 10 years behind most other places, but we just got our O-arm a year or 2 ago. Certainly not a robot yet, and now I'm placing all of my screws in with navigation first, and then placing the tube in between the screws. And actually, it may sound more cumbersome. I think some people may do the inner body work first and then place the screws after, but I find just dropping the tube in between the 2 extension tabs is pretty facile. So here you can see that Metrix tubes, or any type of minimally invasive tube of your choice, is being docked on the inferior facet, aiming at the disc space. Generally, I try to get to a 22 millimeter width tube, although I've certainly had to work through narrower channels. I think probably the most complicated or the most challenging MIS TLIF I did was a 9 centimeter depth via 9 centimeter depth by 20 millimeter width in a patient with a BMI in the high 30s. Here you can see the muscle being stripped off the inferior facet, and then the facetectomy being performed. And again, all working through a pretty narrow tube, essentially relying on the inner body space for the fusion. I don't use a lot of infuse for my 1 and 2 level degen cases. Generally, I'm just grinding up the facet in the bone mill, packing that in the implant, pre-packing the disc space with either a bone graft extender or a different kind of biologic. And at least my results have been pretty good. Here you can see in this patient we're doing, as has been discussed by, I think, both Dr. Schwender and Dr. Fisher, just swinging the tube more contralaterally and completing the laminectomy, ensuring a thorough decompression. And there you can see the ligamentum flavum being pulled off. So can we jump ahead to 10:18? Once the implant's in, then the screws are placed in the typical manner. Here you can see her spondy is reduced, and her neural elements are nice and free. And she did well. Most surgeons aren't putting together videos of patients that don't do well, so that doesn't come as a surprise. So as I mentioned, my techniques changed a little bit since my time in training. Here you see the patients being positioned. The percutaneous pin is placed in the iliac crest. Navigation of your choice. And as is mentioned with navigation, you can really ensure that your screws are well-sized and placed well. So just to go over some of the literature, and I think Dr. Fishers is going to go over this in more detail, but the outcomes comparing MIS and open TLIF, I think, have largely been favorable for MIS. I think the long-term outcomes generally show equivalent, HR QOLs, equivalent fusion rates, but the short-term outcomes demonstrate probably comparable operative times these days, with less blood loss, less postoperative pain, less cost, and shorter hospital stay. So this was a paper put together by Larry Koo and his team, showing really good fusion rates between both MIS and open TLIF at less cost. This showed less disability with an MIS group, as well as a lower VAS back and leg pain scores. This is some work that we did during my time at Michigan, just looking at our MIS TLIF, doing a meta-analysis of the studies available at the time, which again showed excellent fusion rates and good clinical outcomes. And this is another kind of systematic review by Dr. Foley's group, showing, as mentioned, decreased blood loss, length of stay, complications, and similar operative times but for MIS when compared to open. Now, go to a lot of meetings, just like all of you do, and there's, I think, been a lot of talk about whether MIS TLIF is a kyphogenic procedure. And how many of you in here believe that MIS TLIF is kyphogenic?
Certainly can be.
Can be, yes. Dr. Bervin certainly thinks that. I think this, I'll be interested in hearing, of course, Sig's comments on this, but I think that really hasn't borne out to be true. So Juan Uribe, and granted all these are MIS guys and gals doing the writing, but he did a literature review of both MIS TLIF and MIS lateral studies, and actually found that none of the studies where segmental and lumbar lordosis was reported actually had kyphogenesis with MIS TLIF, whereas actually with MIS lateral, there were a few that were kyphogenic. So I don't think MIS TLIF is profoundly lordosis inducing, but I also don't think that it necessarily reverses lordosis and causes kyphosis. This is Portland when it's not raining. And I'd like to invite all of you to our spine section in Miami in March. Thanks very much.